Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the valvular heart disease of cardiology, that is the aortic regurgitation. So, if you take this aortic regurgitation, if you see this aortic regurgitation, what is this? It is a clinical condition which is characterized by regurgitation of blood from aorta to left ventricle during diastole, right? So this is what is called as the aortic regurgitation, right? It is the regurgitation of the blood from aorta to the left ventricle during diastole is what is called as the aortic regurgitation. Now you need to know what are the etiologies which will cause the aortic regurgitation. So if you see the question here, aortic regurgitation does not occur in acute myocardial infarction, Marfan syndrome, rheumatic heart disease, infective endocarditis. So let me tell you, there are two mechanisms or two important etiologies which will cause the aortic regurgitation. So now this will be the left atrium, then you have the left ventricle giving rise to the aorta, and you have the aortic valve. So in this aortic valve you have two components. One is the aortic valve annulus, right? One you have the aortic valve annulus, and then you have the valves, right? Then you have the valves. So the aortic regurgitation can occur either due to the valvular abnormality or this aortic regurgitation can occur due to deformity of the aortic root, right? Due to deformity of the aortic root. So these two abnormalities can make the individual to land up in the aortic regurgitation. Now let me discuss what are the valve abnormalities and what are the aortic root abnormalities which can make the individual to land up in aortic regurgitation. So if you take the valve abnormalities, these valve abnormalities include the rheumatic heart disease, and this will be the most common cause for the development of aortic regurgitation. Then followed by that, infective endocarditis, right? Infective endocarditis. This is another important etiology which will cause the aortic regurgitation. Then congenital bicuspid aortic valve, right? Congenital bicuspid aortic valve can cause the aortic regurgitation. And if you take the aortic root diseases which will cause the aortic regurgitation, that includes the Marfan syndrome, and next important aortic root disease which will cause aortic regurgitation will be osteogenesis imperfecta. Next we have severe hypertension causing aortic regurgitation. Then followed by that the ankylosing spondylitis, then lastly we have syphilis. Okay, so these are the aortic root diseases which will cause the aortic regurgitation. Okay, now after having discussed about the etiologies which will cause the aortic regurgitation, but among all these, what is the most common cause? It is the rheumatic heart disease which will cause the aortic regurgitation. Now you need to know that these patients with, okay, if you see this question now, aortic regurgitation does not occur in acute MI, Marfan syndrome, rheumatic heart disease, infective endocarditis. Let me tell you, in case of acute MI, the valvular heart disease that the individual can develop is the mitral regurgitation but not the aortic regurgitation. But Marfan syndrome, it is a connective tissue disorder where there is the abnormality within the collagen which will cause the aortic root dilatation causing the aortic regurgitation. Then followed by that the rheumatic heart disease where the pathology is in the valves, and then followed by that infective endocarditis. So these are all the etiologies which will cause aortic regurgitation, but acute MI will not cause the aortic regurgitation. Now you need to know the clinical presentation of the patients with aortic regurgitation. It can be in two forms. One is your acute aortic regurgitation and the other one is chronic aortic regurgitation. So in acute aortic regurgitation, right, see what are the etiologies which can cause acute aortic regurgitation that can be seen in patients in aortic dissection, right, and another important etiology is infective endocarditis. Okay, so these are the two important etiologies which will cause the acute aortic regurgitation. And what will be the clinical presentation of the acute aortic regurgitation? The clinical presentation will be in the form of LV failure. That is left ventricular failure. And this left ventricular failure, it is manifested or it is presented in the individual in the form of the pulmonary edema, right? So the presentation is in the form of, right, presentation is in the form of pulmonary edema, and this pulmonary edema, it develops rapidly, right, this pulmonary edema, it develops rapidly. And these patients with acute aortic regurgitation, surgery is urgently required in such cases. Okay, right, surgical treatment is required urgently in such cases. And in these patients with acute aortic regurgitation, let me tell you, they do not have dilated left ventricle, right? So there is no dilated left ventricle. Whereas you take in case of chronic aortic regurgitation. In chronic aortic regurgitation, the blood from the aorta will be chronically regurgitating back into the left ventricle, and left ventricular end-systolic volume increases, and thereby in chronic aortic regurgitation you have the presence of the dilated left ventricle, right? Whereas in case of acute aortic regurgitation, you don't have the dilated left ventricle. Now, because there is no dilated left ventricle, this is the reason why the diastolic murmur, it is short, right? See, in patients with aortic regurgitation, you have EDM. So what does the EDM stands for? EDM stands for the early diastolic murmur, and this particular early diastolic murmur, it will be very short, right? This diastolic murmur, it is shorter and it is minimal in intensity, right? It is minimal in intensity. And in these patients with the aortic regurgitation, pulse pressure may not be widened. Okay, so there is no wide pulse pressure, right? There is no wide pulse pressure. Okay, see, actually in patients with aortic regurgitation, the characteristic feature whenever you are recording the blood pressure is that there will be widened pulse pressure, but here there is no wide pulse pressure, and making the clinical diagnosis difficult, right? Making the clinical diagnosis difficult. Okay, So these are some of the important features in patients with acute aortic regurgitation. Let me repeat. So in case of acute aortic regurgitation, what are the etiologies? It is secondary to aortic dissection or the infective endocarditis. And in these individuals, there will be development of LV failure, and that is manifested primarily as pulmonary edema, and this LV failure, it develops rapidly. And in these patients with acute aortic regurgitation, surgery is urgently required in such cases. And patients with acute aortic regurgitation do not have the dilated left ventricle, right? They do not have the dilated left ventricle of the chronic aortic regurgitation. In chronic aortic regurgitation, you have the presence of the dilated ventricle, left ventricle, but you don't have the same in case of the acute aortic regurgitation, right? And the next important point is the diastolic murmur in patients with aortic regurgitation is shorter and it is minimal in intensity, and even pulse pressure may not be widened. And that is the reason why the clinical diagnosis of the acute aortic regurgitation is slightly difficult. Okay, next, followed by that, the chronic aortic regurgitation. See, the clinical presentation in case of chronic aortic regurgitation is determined by rapidity with which the regurgitation develops. See, for example, if the regurgitation develops rapidly, then the individual will land up in acute left ventricular failure, acute pulmonary edema, and there will be rapid onset of dyspnea. But these chronic aortic regurgitation patients, most of these patients, they remain asymptomatic for long periods. Right? They remain asymptomatic for long periods. And in these individuals with chronic aortic regurgitation, left ventricular failure is a late event. Right? Left ventricular failure is a late event in this individual. And what will be the clinical presentation in case of chronic aortic regurgitation? The clinical presentation in case of chronic aortic regurgitation will be exertional dyspnea and fatigue. These are the most frequent symptoms, right? Exertional dyspnea and fatigue. These are the most frequent symptoms, okay? And apart from that, the paroxysmal nocturnal dyspnea will be there, and pulmonary edema may also develop. So as the severity progresses, these individuals will land up in pulmonary edema, and once they develop pulmonary edema, frank pulmonary edema, they will have acute onset breathlessness. Now, and why is that they develop this exertional dyspnea and as well as fatigue is because the left ventricle in case of aortic regurgitation is chronically receiving the blood. So it is like you can see that here. So the blood from the aorta is regurgitating back into the left ventricle during diastole. But this same left ventricle will be also receiving the blood from the left atrium during diastole. So thereby what will happen to the LV end diastolic volume? The LV end diastolic volume is increased, right? LV end diastolic volume is increased. So once this LV end diastolic volume increases, at one point of time the left ventricle fails, right? Left ventricle, it gets dilated for a longer duration of time and it gets enlarged, and at one point of time the left ventricle fails. Okay, so once the left ventricle fails, that is the point when the individual will land up in the development of pulmonary edema, and then there will be dyspnea. And once there is left ventricular failure, even the cardiac output is also reduced. So as the cardiac output is reduced, these individuals, right, these individuals will develop fatigue, right? Next, now another important clinical manifestation in case of chronic aortic regurgitation will be angina pectoris or atypical chest pain. right? Angina pectoris or atypical chest pain. So why is that you will have this angina pectoris or atypical chest pain is because the left ventricle, it gets dilated. There will be left ventricular hypertrophy. But what type of hypertrophy you will have here in aortic regurgitation? It is an eccentric hypertrophy. Whereas in aortic stenosis, what you have is concentric hypertrophy. So whenever there is eccentric hypertrophy of the left ventricle requires more blood in order to reach the myocardial oxygen demand. But here, once the left ventricle fails, the cardiac output is getting reduced. So once the cardiac output is getting reduced, the blood supply to the hypertrophied left ventricle will be reduced, and thereby the individual will have ischemia, resulting in the angina pectoris or atypical chest pain, right? And associated coronary artery disease and pre-syncope or syncope are less common than in aortic stenosis. Okay, so in aortic stenosis, right, in aortic stenosis, you have the presence of the associated coronary artery disease, right? You have the presence of associated coronary artery disease, or there can be even syncopal attack. So this associated coronary artery disease and syncopal attack, it is less common in patients with the aortic regurgitation, right? And in chronic aortic regurgitation, the only sign for many years may be a soft aortic diastolic murmur. And what will be the examination findings in patients with aortic regurgitation? We will discuss. So you have many peripheral signs. You have many peripheral signs in patients with the chronic aortic regurgitation. Let me tell you, the peripheral signs are not present in case of the acute aortic regurgitation. But the peripheral signs which I am about to discuss, they are present only in chronic aortic regurgitation. So if you see this point, the major physical findings in chronic aortic regurgitation relate to high stroke volume being ejected into the systemic vascular system with rapid runoff at the as the regurgitation takes place. So what does that mean? I'll tell you here. So consider this is your left side of the heart, that is the left atrium, then left ventricle, then you have the aortic valve. So in aortic regurgitation, what is happening? The blood from the aorta is regurgitating back into the left ventricle, and at the same time the blood from the left atrium is also entering into the left ventricle. So thereby what will happen to the LV end diastolic volume? The LV end diastolic volume increases. So as the LV end diastolic volume increases, what will happen to your stroke volume? There will be high stroke volume, right? There will be high stroke volume. So once there is a high stroke volume, there is a rapid ejection of the blood into the peripheral circulation, that is into all the peripheral vessels, and thereby you will have, a bounding pulse. And at the same time, during diastole, right? And at the same time, during diastole, what happens? During diastole, the blood from the aorta will regurgitate back into the ventricle. So there will be diastolic runoff, right? There will be diastolic runoff. There will be rapid runoff from the aorta into the left ventricle, right? There will be rapid runoff from the aorta into the left ventricle during the diastole. So during systole, a large quantity of the blood is entering into the peripheral circulation, and during diastole, similarly, the quantity of the blood is regurgitating back into the left ventricle. So you will have a bounding pulse and then a collapse. So the mechanism of all the peripheral signs which I am about to discuss is mainly because of this particular reason. Now I'll just show you one important question. Durosi's sign, it is seen in the aortic regurgitation, tricuspid regurgitation, mitral stenosis, the pericardial effusion. Durosi's sign, it is seen in patients with the aortic regurgitation, right? Durosi's sign, it is seen in patients with the aortic regurgitation. Now let me discuss all the peripheral signs, and your Durosi's sign, it is also one of your peripheral sign of the aortic regurgitation. Now coming to the peripheral signs, right? Coming to the peripheral signs. So If you see the peripheral signs of aortic regurgitation, see there are almost like 15 to 16 peripheral signs in patients with aortic regurgitation. So you just start from the hands, then go to the neck, head, abdomen, and then the lower limbs. Okay. So all these peripheral signs are produced as a result of wide pulse pressure. They are produced as a result of wide pulse pressure. Now, what are those peripheral signs? That includes number one, visible capillary pulsations, right? Visible capillary pulsations. And that visible capillary pulsations, we call it as the Quincke's sign. And where is that you will observe this visible capillary pulsations within the Quincke's sign is, that is at the that is at the nail beds or lips, right? That is at the nail beds or lips. And what is that you will have? You will have blanching and quick refill. Right? You have blanching and then quick refill. That is what you will observe at the nail beds or lips. And for eliciting this Quincke's sign, what is the procedure that you need to follow? Right? You see, this is the tip of the nail. You need to apply the light pressure, right? Light pressure is applied to the tip of the fingers or the nails. Okay, light pressure is applied to the tip of the fingers or nails. And when light pressure is applied to the tip of the fingers or nails, what is that you will observe is, you can see the digital blood vessels, right? You can see that capillaries. So within the capillaries, you can observe there is alternate flushing and pallor of the nail bed. Right? Alternate flushing and pallor of the nail bed. Right? So that is what is your Quincke's sign, which is nothing but your visible capillary pulsations. Now, after having discussed about the Quincke's sign, the another important sign that you will make out at the tip of the fingers is the prominent digital artery pulsations. See, in order to demonstrate or in order to elicit this prominent digital artery pulsations, what you need to do is, you hold the flexed fingers of the patient with your flexed fingers in flexed position, right? Flexed finger of the patient with your fingers in flexed position to feel the pulsations. So consider this is like the patient's fingers, right, where you have the presence of the digital arteries, and then you apply your fingers over the tip of the fingers of the patient, where you can make out that prominent digital artery pulsations. So in order to demonstrate this, what you need to do is hold the flexed fingers the whole flexed fingers of the patient with your fingers in flexed position. Right, with your fingers in flexed position to feel the pulsation. Right, to feel the pulsations. That is what is called as the prominent digital artery pulsations. Then followed by that, the next important pulse is the water hammer pulse. Now what do you mean by this water hammer pulse and how will you demonstrate this? See, in order to demonstrate this water hammer pulse, you need to raise the arm of the individual. right? You need to raise the arm of the individual. And what is that you will make out? So, water hammer pulse, another name of it is also called Corrigan's pulse. Right, this is also called Corrigan's pulse, or it is a high volume collapsing pulse. Right, it is a high volume collapsing pulse. See, in case of the water hammer pulse, what is that you will be able to make out? Whenever there is left ventricular systole, there is large quantity of the blood which will enter into the aorta. So there is increased stroke volume. That increased stroke volume will hit the vessel, right? So you will have a rapid upstroke. And when you are raising the arm, what is that you are making? You are aligning the radial artery exactly towards your left ventricle. So radial artery, which is the continuation of the brachial artery, which is the continuation of the axillary artery, which is a continuation of the subclavian trunk, and subclavian trunk is continuation of the arch of aorta continuation of ascending aorta it is coming from your left ventricle. So you are keeping the radial artery exactly in the alignment of the left ventricle. So you will have a rapid upstroke, and then during diastole you will have a collapse. So that is nothing but it is a high volume, that is during systole, collapsing pulse, that is during diastole. That is called as the water hammer pulse. Now, another important peripheral sign in patients with the aortic regurgitation is the locomotor brachialis. See, locomotor brachialis, where is that you will observe is, you need to look at the medial side of the lower arm with semi-flexed elbow. Right, medial side of lower arm in semi-flexed elbow. Okay, so you need to know, right, you need to know that whenever you observe the medial side of the lower arm in semi-flexed elbow, you will be able to make out the tortuous and highly pulsatile brachial artery. See, this is your tortuous and highly pulsatile brachial artery. Right, highly pulsatile brachial artery. That is what is your locomotor brachialis, right? So tortuosity, right, this particular tortuosity is the most important component of the locomotor brachialis. Okay, right, this is most important component of the locomotor brachialis. And this locomotor brachialis, it is also commonly found in atherosclerosis. Right, it is also commonly found in atherosclerosis, that is in old age. Right, that is in old age. So that is about the locomotor brachialis. And the next important peripheral sign or next important abnormality that you will have in aortic regurgitation is regarding the blood pressure. See, these individuals, they will have high systolic blood pressure and they will have low diastolic blood pressure. So thereby, what will happen to the pulse pressure of the individual? They will have a very high pulse pressure. See, how do you calculate the pulse pressure? Pulse pressure, it is given by the formula systolic blood pressure minus the diastolic blood pressure. That is what is called as the pulse pressure. And you know, the diastolic blood pressure may be so low that it may continue or it may go even up to 0 millimeters of mercury. Right? It may go even up to 0 millimeters of mercury. Right? So that is about your blood pressure. So whatever we have discussed in the arm, you see now, in the tip of the nail, we have discussed the Quincke's sign and the prominent digital artery pulsations. Right? That prominent digital artery pulsations is also one of the important peripheral sign. Then if you take the pulse, Corrigan's pulse or water hammer pulse, and then if you take the blood pressure, they have increased pulse pressure. Right? They have increased pulse pressure. And then over the medial side of the arm in a flexed position, you have the presence of the locomotor brachialis. Now, so these are the peripheral signs within the arm. Now, we will move on to the neck. So, if you see the signs in the neck, the very important sign like what we have is the Corrigan's sign. This Corrigan's sign, it is nothing but the dancing carotid. So, this dancing carotid, so you can observe this is a prominent carotid artery. So, this dancing carotids in the neck, right, dancing carotids in the neck are seen in case of aortic regurgitation, that is during systole. There will be rapid upstroke, and during diastole there will be a collapse. Right, so that is what is your Corrigan's sign, which is nothing but the dancing carotids in the neck. Then we have another important peripheral sign within the neck itself, that is called as the de Musset sign. See, the name de Musset's, it is named after a French poet. Right, it is named after the French poet. And what is that you will observe in the de Musset sign is to and fro head nodding synchronous with carotid pulsations. So, you can see this particular head. Okay, so to and fro. Right, to and fro head nodding, and this to and fro head nodding, it is synchronous with carotid pulsations. Right, synchronous with carotid pulsations. That is called as the de Musset sign. Okay, next, apart from that, in the suprasternal area or in the suprasternal notch, you will also observe the visible pulsations. Right, visible pulsations can be seen in the suprasternal notch, which is also called the jugular notch. Right, which is also called the jugular notch. So what is de Musset sign? De Musset sign is the one which is named after a French poet, where you have to and fro head nodding, which is synchronous with the carotid pulsations. And apart from that, in the neck, you also have the visible pulsations in the suprasternal notch, which is also called jugular notch. Now, so these are the two important signs in the neck. One is your Corrigan sign, which is nothing but dancing carotids in the neck. And the next important thing is the de Musset sign, which is to and fro head nodding synchronous with the carotid pulsations. Next. Following that, you have what is called the Landolfi's sign. Now, what is this Landolfi's sign? See, you need to observe the pupil. Right? So, in the Landolfi's sign, you need to observe the pupil. So, what is this? The pupillary changes. So, it is change in pupil right, change in pupil size with each cardiac systole. Right, change in the pupil size with each cardiac systole is called Landolfi's sign. Then followed by that, the another important peripheral sign is the lighthouse sign. So what is this particular lighthouse sign? Lighthouse sign is alternate flushing and blanching of the forehead. Right? Alternate flushing and blanching of the forehead. Okay, so that is what is called as the lighthouse sign, where you have alternate flushing and blanching of the forehead is known as the lighthouse sign. Next, followed by that, you have the Becker sign. See, in the head, now what all the signs we have discussed until now? One is lighthouse sign, right? That is alternate flushing and blanching over the forehead. And then we have discussed in the eye, that is Landolfi's sign, that is changes in the pupil size with each cardiac systole is known as the Landolfi's sign. Then followed by that, we have the Becker sign. See, what is Becker sign? Becker sign is the pulsations of retinal artery is the Becker sign. Right, pulsations of the retinal artery is called the Becker sign, and this pulsations within the retinal artery will be there with every systole and as well as the diastole. So these are the signs, these are the two important signs in the eye. Now how to remember this Becker sign? See, the word Becker, right, it is ending with word R, and retinal artery, it is also starting with letter R. So that is nothing but your Becker. Okay. And next, you have the very important sign within the mouth, and that is called the Muller sign. Now, what is Muller sign? Muller sign it is, right? Muller sign it is pulsations in the uvula. Right? Pulsations in the uvula. That is called the Muller sign. So, how do you represent, how do you remember that? So, just please, this U, Muller's, okay? So, the one which will start with the word U. So, pulsations in the uvula is nothing but your Muller sign. Then, so we have discussed about the signs in the neck and as well as the head. So, in the neck it is Corrigan sign, which is nothing but the dancing carotid. Demoset sign, which is to and fro movement of the head, which is synchronous with each cardiac cycle. Then you also have the pulsations within the suprasternal notch, which is nothing but the jugular notch. And within the head, we have the lighthouse sign, which is the alternate blanching and flushing over the forehead. And within the pupil or within the eye, we have pulsations within the retinal artery, that is Becker sign, and pulsations within the pupil, right? The pulsations within the pupil, that is called Landolfi's sign, and then pulsations within the uvula, that is nothing but your Muller sign. Okay, so and after that, let me discuss about the Rosenbach sign and as well as the Gerhardt sign. So this Rosenbach sign and as well as the Gerhardt sign, these are the two important signs within the abdomen. So if you take the Rosenbach sign, it is the pulsations which you feel over the liver, right? The pulsations that are felt over the liver, that is nothing but your Rosenbach sign. Then followed by that, what is this Gerhardt sign? See, Gerhardt sign, it is the pulsations over the enlarged spleen. Right, pulsations over the enlarged spleen is called the Gerhardt sign. So these are the two important signs like that you will see over the abdomen. Then followed by that, we have the next important sign, that is called as the Trops sign. See, what is this Trops sign is? Trops sign, it is, you will auscultate or you will hear pistol shot sounds over, right? This Trops sign, it is also called, right, it is also called pistol shot sounds. Now this Trops sign or pistol shot sounds is that where the individual will have right, where the individual will have booming sound produced after pressing the stethoscope over the femoral artery, right. So it is a booming sound which is produced after pressing the stethoscope over the femoral artery. That is what is called as the trop sign or the pistol shot sounds, right, which is nothing but the booming sound which is produced after pressing the stethoscope over the femoral artery, that is called the trop sign. Now, within the lower limbs, we have three more signs. We have what is called the Durose's murmur. Now, what is this Durose's murmur? Let me discuss. Okay, so please consider this is the femoral artery, right, and over the femoral artery, you place the diaphragm or the stethoscope, right? You need to place the diaphragm or the stethoscope, and after placing the stethoscope, you compress the femoral artery proximally, right? You compress the femoral artery proximally. So once you compress the femoral artery proximally, the murmur that you listen is the systolic murmur. And once you compress the femoral artery distally, then what you have is the diastolic murmur, or what you will listen is the diastolic murmur. Okay, so this distal diastolic murmur, whatever is heard, this is nothing but your Durose's murmur. Right, this is nothing but your Durose's murmur. Then what is this Durose's sign? So the systolic murmur and diastolic murmur together, it is called Durose's sign. Right, systolic murmur and diastolic murmur together, it is called the Durose's sign. So this is about another important peripheral sign that you will have in aortic regurgitation. Then followed by that, you need to know about the Hill's sign. Now what is this particular Hill's sign? Now first of all, let me tell you in the normal individual, and then what is this Hill's sign in aortic regurgitation, let me discuss. So if you take the blood pressure of the lower limb and as well as the upper limb, the blood pressure of the lower limb will be more than compared to that of the blood pressure of the upper limb in a normal individual. And how much will be that, right? How much will be that in case of a normal individual? So the blood pressure in the lower limb is more than compared to that of the upper limb, normally up to 20 millimeters of mercury, right, up to 20 millimeters of mercury. Whereas in Hill's sign, you will have that Hill's sign in aortic regurgitation. And if you see the blood pressure of the lower limb then compared to that of the upper limb, the blood pressure in the lower limb will be more than 20 millimeters of mercury than the upper limb. Right, more than 20 millimeters of mercury then compared to that of the upper limb, and that is what is called as the Hill's sign, right, that is what is called as the Hill's sign. And this particular Hill's sign, it also tells you about the severity of right, this also tells you about the severity of the aortic regurgitation. Right, so more is the difference of the blood pressure between the upper limbs and as well as the lower limbs, more severe is your Hill's sign or more severe is your aortic regurgitation. So the Hill's sign, it also tells you about the severity of the aortic regurgitation as well. So in the lower limbs, we have discussed four important signs. One is your Trop sign, then Durose's murmur, Durose's sign, and then followed by that the Hill sign. So these are the four important signs, okay, in the lower limb. So now you just see the sequence. Tip of the nail, Quincke's sign, then prominent digital artery pulsations, then the pulse, it is the Corrigan's pulse or water hammer pulse, and blood pressure, a blood pressure with wide pulse pressure, then locomotor brachialis over the arm, right? So these are the signs within the fingers, forearm and then arm. Then you take within the neck, de Musset sign, that is head nodding, Corrigan's sign, that is dancing carotid, and prominent pulsations within the jugular notch or suprasternal notch. These are the signs in the neck. Then in the face or in the eyes or in the mouth. So over the forehead, lighthouse sign, that is alternate flushing and blanching over the forehead. Then you take within the eye, Landolfi's sign, right, where the pulsations you will see within the pupil. Then Becker's sign, the pulsations in the retinal artery. Then in the uvula, that is the pulsations within the Muller's sign. Muller's sign is nothing but the pulsations within the uvula. That is called Muller's sign. Then you come onto the abdomen. So within the abdomen, the pulsations that you feel over the liver is the Rosenbach sign, and the pulsations what you feel over the spleen is nothing but your Gerhard sign. Then come on to the lower limbs. So in the lower limbs, four important signs. What are those four important signs? That is the Trop sign, Hill sign, Durose's murmur, and then Durose's sign. So these are all the peripheral signs of aortic regurgitation. And one more important sign, particularly in females, that is Shelley's sign. So if you take this Shelley's sign, it is the pulsations that are being felt over the cervix, right? Pulsations that are being felt over the cervix, that is called as the Shelley's sign, and seen only in females. So let me tell you, more is your peripheral signs, severe is your aortic regurgitation. So please remember, this is a very, very important point. Next, the another important question is, wide pulse pressure is seen in aortic regurgitation, patent ductus arteriosus, mitral regurgitation, aortic stenosis, the congestive cardiac failure. So wide pulse pressure is not just seen only in patients with aortic regurgitation. There are many clinical conditions where you have the wide pulse pressure. And when is that you will use the terminology that there is wide pulse pressure? When the pulse pressure of the individual is more than 60 millimeters of mercury, that is the point when we use the word wide pulse pressure. And we have this wide pulse pressure in patients with aortic regurgitation, then mitral regurgitation. So why is that you will have wide pulse pressure? That is due to high systolic blood pressure and due to low diastolic blood pressure. That is the reason why you have the wide pulse pressure. And the other scenarios where you have the wide pulse pressure is the PDA, that is patent ductus arteriosus, then VSD, that is ventricular septal defect, next anxiety, followed by that anemia, exercise, fever, pregnancy, then AV fistula. So these are all the conditions, right? These are all the conditions where you have the wide pulse pressure. So all these, anemia, exercise, fever, pregnancy, AV fistula, all these are the high output states. Right, all these, they are high output states or they are called hyperkinetic states. Then followed by that, how will you diagnose the aortic regurgitation? See, the diagnosis of aortic regurgitation is done by the ECG, that is the electrocardiogram. and the 2D echo. Then the chest X-ray. Next, cardiac catheterization. But what will be the first line investigation? That is the 2D echo. So 2D echo will be the first line investigation. Now, what will be the changes in the ECG? Let me discuss one by one. So in the ECG, what is that you will observe? The presence of the hypertrophy, because in aortic regurgitation you have the eccentric hypertrophy. So you will have the features of the hypertrophy. Now what are the features of the hypertrophy? Right, what are the features of the hypertrophy in the ECG? So you will have deep S wave in V1, then you will have large R wave in V5 or V6. So what is the criteria for left ventricular hypertrophy is SV1, that is S wave in V1 plus R wave in V6 plus R wave in V6. The amplitude should be, when you sum both of this, it should be more than 35 mm. Right, this should be more than 35 mm. That is what is the features of left ventricular hypertrophy, which is there here. And see, in aortic regurgitation, what you will have is the volume overload of the left ventricle. Right, what you will have is volume overload of the left ventricle. So because of this volume overload, you have the presence of the Q wave. Right, because of the volume overload of the left ventricle, you have the presence of the deep Q wave. So you can observe this, or you can appreciate this Q wave. Okay, see, this is a Q wave. Right, this is a Q wave. So you have the deep Q wave. So please remember, if you have the presence of a deep Q wave, that is suggestive of volume overload state. Right, that is suggestive of volume overload condition. So this will be the ECG changes. Number one, features of hypertrophy. Number two, you have the features of volume overload, which is represented by the deep Q wave in the respective leads. Then followed by that, the chest X-ray. See, what is that you will be able to make out within the chest X-ray is, the chest X-ray, it will show you the cardiomegaly, and this particular cardiomegaly is due to left ventricular dilatation. Right, this cardiomegaly is due to left ventricular dilatation, and you can see that apex of the left ventricle, it is shifted down and out. Right, the apex of the left ventricle, you can make out that it is shifted down and as well as out. That is what you will have in case of the cardiomegaly. Okay, that is what is your left ventricle in case of the aortic regurgitation, right, which is shifted down and as well as out. Okay, next, then followed by that, you can make out the cardiothoracic ratio. The cardiothoracic ratio is increased, and this cardiothoracic ratio, right, this cardiothoracic ratio, it will be more than 0.5. That is what you will have in the chest X-ray of the aortic regurgitation, and you will also able to make out the aortic dilatation within the chest X-ray. Right, aortic dilatation within the chest X-ray. So this will be the chest X-ray picture in patients with the aortic regurgitation. Then the next important investigation is the echocardiography. See, what is that you will be able to make out? First of all, I said you this will be the first line investigation. There will be dilated left ventricle and as well as the aorta. So left ventricle, even left ventricular end-systolic diameter is increased, and as well as left ventricular end-diastolic diameter is also increased. Both of them are increased. Left ventricular end-systolic diameter and left ventricular end-diastolic diameter is also increased in these patients with the aortic regurgitation. And you will be able to make out left ventricular volume overload during diastole. So during diastole, you can make out that there is increase in the left ventricular end-diastolic volume, and you can also make out fluttering of the anterior mitral leaflet. See the regurgitant jet, right? So this will be your left atrium, then left ventricle giving rise to the aorta, and this will be the aortic valve, and this will be the regurgitant jet. So this regurgitant jet, it can hit the anterior mitral leaflet. So once the anterior mitral leaflet is being hit by the regurgitant jet, you will observe the fluttering of anterior mitral leaflet. Right, fluttering of the anterior mitral leaflet. Okay, so that is what you will observe in the 2D echo. So this will be the 2D echo features in patients with the aortic regurgitation. And definitely, what is a confirmatory investigation? That is your cardiac catheterization. So now these patients, we also have to do cardiac catheterization. See, what is the purpose of doing cardiac catheterization is that one thing you will confirm the aortic regurgitation, and you also need to do coronary angiogram to rule out associated coronary artery disease, right? To rule out associated coronary artery disease. So that is the purpose why you need to do the coronary angiogram. Let me discuss this, or let me tell you this in detail. Now, a patient with severe aortic regurgitation, you want to take the patient to surgery, right? You want to do surgical aortic valve replacement, or you want to put a prosthetic valve. Same time you need to do coronary angiogram before taking to the surgery. Why? If there is associated coronary artery disease, parallelly you also have to do coronary artery bypass graft, CABG, and that is the reason why you need to do the coronary angiogram before taking the patient to surgical aortic valve replacement. Okay, next, followed by that the treatment. Now, if you see the treatment in these individuals, right, we have the medical management and as well as the surgical treatment. See, medical management, you need to give diuretics, right? So we give the furosemide. So if it is like acute aortic regurgitation, right, if it is like acute aortic regurgitation, we need to give diuretics, that is the furosemide, in case of acute aortic regurgitation. Okay, but for suppose if the individual is having chronic aortic regurgitation, then you can give the oral formulations as well, right? Even oral formulations like torsemide and as well as the bumetanide can be given. Okay, so that is what is your supplementation of diuretics. And then you also need to give the drugs for afterload reduction. So what are the drugs which are given for, right, what are the drugs which are given for afterload reduction? We give AC inhibitors, and if the individual is not tolerating the AC inhibitors because of the development of dry cough, then you need to give angiotensin receptor blockers. So these AC inhibitors or ARBs, they will cause the decrease in the pressure within the aorta, and once they decrease the pressure within the aorta, afterload on the left ventricle will be reduced. And the next important point is that we need to give the potassium sparing diuretics, that is spironolactone. And spironolactone, it is mainly given to prevent the cardiac remodeling. That is about the ACE inhibitors and as well as ARBs and as well as the spironolactone. And what about the beta blockers? Can we give beta blockers in these patients? Please remember, beta blockers, they are usually avoided. Now you need to know why the beta blockers are being avoided, right? What is the mechanism? Why you should avoid the beta blockers? See, beta blockers whenever you give, they decrease the heart rate of the individual, and thereby what they will do? They will increase the diastolic time, right? They will increase the diastolic time. Okay, so when there is diastolic time is increased, the quantity of regurgitation increases, right? The quantity of regurgitation into the left ventricle increases. That is the reason why you should not give beta blockers. So beta blockers are usually avoided in these patients with the aortic regurgitation. Then you see a question here: which of the following is contraindicated in the treatment of acute severe aortic regurgitation? Intravenous diuretics, sodium nitroprusside, intra-aortic balloon pump, then surgery. So if you take the management of acute severe aortic regurgitation, so management of acute severe aortic regurgitation, you need to give intravenous diuretics. And what is that intravenous diuretics that we give? That is furosemide. Okay, because the individual will end up in acute pulmonary edema, wherein the individual will have acute onset breathlessness. So to avoid that, we give this intravenous diuretics, that is furosemide. Then the other important drug is you need to give sodium nitroprusside. See, what is the purpose of giving this sodium nitroprusside? The purpose of giving this sodium nitroprusside is mainly to decrease the afterload on the heart. Right, to decrease the afterload on the heart. That is the purpose of giving the sodium nitroprusside. Okay, see, now in the recent days, there are certain problems with the sodium nitroprusside. Sodium nitroprusside, it can cause cyanide toxicity. So in order to prevent that cyanide toxicity, instead of giving sodium nitroprusside, we can give the nitrates, that is nitroglycerin. Even that also will reduce the afterload on the left ventricle. And then ACE inhibitors or ARBs can be given. And these patients with the acute severe aortic regurgitation, surgery is the treatment of choice. Right, surgery is the treatment of choice, and it is usually necessary within 24 hours of diagnosis. Right, this is usually done within 24 hours of the diagnosis. So that is about the surgery. And please remember, in acute aortic regurgitation also, beta blockers are best avoided, because when you give beta blockers, they will slow the heart rate and thereby increasing the diastolic time and increasing the aortic regurgitation. And now in this patient, the one which is contraindicated is the intra-aortic balloon pump. Now what is this intra-aortic balloon pump and where do we use this intra-aortic balloon pump? See, intra-aortic balloon pump, I'll just show you this. This is the intra-aortic balloon pump, that is IABP. The actual indication of IABP is to place that in patients with the cardiogenic shock. Right, to place that in patients with the cardiogenic shock. Now, what does this IABP does? See, this IABP, it will pump or it will inflate the balloon during diastole. Right, it will inflate the balloon in the diastole. And where is this balloon placed? This particular balloon, it is placed in the descending aorta. Right, this balloon is placed in the descending aorta. And where exactly in the descending aorta? That is distal to left subclavian artery. And you have to place it up to renal artery, that is above the renal artery. So that is the placement of the intra-aortic balloon pump. And what this intra-aortic balloon pump does, whenever the balloon is inflated during diastole, the pressure within the aorta increases during diastole. So once the pressure within the aorta increases during diastole, the blood from the aorta will enter into the coronary arteries. Right? The blood from the aorta enters into the coronary arteries during diastole. Actually, if you take, our entire body will receive the blood during systole. Right? Our entire body will receive the blood during systole. But the heart will receive the blood during diastole and thereby increasing the coronary perfusion. Right? Thereby increasing the coronary perfusion. So that is what will happen with the usage of IABP. So that means IABP, what is it doing? It is increasing the diastolic pressure in the aorta. Right? It is increasing the diastolic pressure within the aorta. That is what is done by your IABP. So when you are increasing the diastolic pressure in the aorta, can you give that in aortic regurgitation? No. Why? Because in aortic regurgitation, once the diastolic pressure is increased, the blood from the aorta will leak back into the left ventricle during diastole. Right? The blood from the aorta will leak back into the left ventricle during diastole. And when you are increasing the diastolic pressure, more and more regurgitation will be there in aortic regurgitation. So that is the reason why in aortic regurgitation, intra-aortic balloon pump is absolutely contraindicated. Okay. Now what are the causes for acute severe aortic regurgitation? Infective endocarditis. Dissecting aneurysm of the aorta can make the individual to land up in the aortic regurgitation. Now, when to operate? Right, what is the indication for surgery in chronic severe aortic regurgitation? Let me tell you, all symptomatic patients, right, symptomatic aortic regurgitation, these patients, they have to undergo surgical treatment of the aortic valve. Okay, and this will be class 1 recommendation. Right, and what about asymptomatic patients? Even asymptomatic aortic regurgitation, even these patients, they have to undergo the surgical treatment. But what is the indication in case of asymptomatic chronic severe aortic regurgitation? The indication is, number 1, when there is abnormal left ventricular ejection fraction less than 50%, right, abnormal left ventricular ejection fraction less than 50%, and when the individual is undergoing other heart surgery, right, when the individual is undergoing other heart surgery and having aortic regurgitation, like the individual undergoing CABG, and parallelly the individual is also having asymptomatic AR, surgical treatment has to be done. That is also class 1 recommendation. And normal left ventricular ejection fraction, right, ejection fraction is more than 50%, but LV end-systolic diameter, right, LV end-systolic diameter is more than 50 mm. But this will be class 2 recommendation. It is not class 1 recommendation, it is class 2 recommendation. And another scenario is normal left ventricular ejection fraction with LV end diastolic diameter, right, with LV end diastolic diameter more than 65 mm. Even this is also a class 2B recommendation. So this is about the indications for surgery in patients with the aortic regurgitation, right? Now, after having discussed about the treatment of aortic regurgitation, you just see this question. All are associated with pulse being checked in this picture except Durose's sign, early diastolic murmur, decreased LV and diastolic pressure, pulsus bispherians. So let me tell you that whatever you are eliciting here, it is the Corrigan's pulse. And this Corrigan's pulse, it is seen in aortic regurgitation. And in aortic regurgitation, let me tell you, you have the presence of Durose's sign. You have the early diastolic murmur. And in severe AR, even you have the presence of the pulsus bispherians, but decreased LV and diastolic pressure is not the feature in case of the aortic regurgitation. In case of aortic regurgitation, let me tell you, there is increased LV and diastolic pressure. Right, there is increased LV and diastolic pressure. Okay, so that is what you will see in the aortic regurgitation. And if you take this pulsus bispherians, what are the other conditions where you have this pulsus bispherians? So pulsus bispherians can be seen in the HOCM. First of all, what is pulsus bispherians? It is the disorder which is characterized by two peaks in systole. Right, characterized by two peaks in systole, that is called as the pulsus bispherians, and it can be seen in hypertrophic obstructive cardiomyopathy, seen in patients with aortic regurgitation, seen in patients with aortic stenosis with aortic regurgitation. These are all the conditions where you have the presence of the pulsus bispherians. And finally, if you see the essentials of the diagnosis, usually asymptomatic until middle age, and patients with left-sided failure or rarely chest pain, right? If at all, if they are symptomatic, they will have the features of left-sided failure and rarely they will have chest pain. And what is diagnostic? Echocardiography, it will be the first line investigation. And if at all, if the individual is symptomatic, surgical treatment of the aortic valve has to be done. And the other indications for surgery is ejection fraction less than 50%, LV end-systolic dimension diameter more than 50 mm, LV end-diastolic dimension greater than 65 mm. So these are all the indications for surgery in patients with aortic regurgitation. So this completes the discussion of the very important topic, that is aortic regurgitation. Thank you very much.